of our residents a couple of years ago. I'm part of the Nanaimo faculty, and I'm sort of specialist interested in the information side of things, managing information. And tonight I'd like to talk about why we should practice it, not necessarily giving clinical answers tonight. I'd like to allow you to have the tools to find clinical answers yourselves and try and find it quickly. So firstly I'm going to play a video from, I don't know if you know Mike Allen and James McCormack, the group that run the Therapeutics Initiative, two pharmacologists and a physician. And the Therapeutics Initiative is solely based in evidence-based medicine. They do a lot of videos, different videos and spoofs on songs, and they're really quite good at providing evidence-based medicine in an accessible, fun way. So I'll play a video from them first, and then we'll move on to the starts off slow, but we'll just watch through the video. And they're very similar to that. So if you want to look at more of the videos, then you just Google their names. It's on their sheets, I think. James McCormack and Mark Allen. So they do lots of different ones. And there's a couple of new ones since I did my last talk, which again, I watched and they're very amusing. So I encourage you to look. And I've got to say at the beginning, if you have any questions, please ask them and take them up. So we've got a mic that's going to be roving around. So if you want to ask any questions, please pipe up as soon as you need to. So for our agenda tonight, what is evidence-based medicine, and what do I think it is? What do you think it is? How do we practice it, and how do we stay up to date? And how do I ask a clinical question? I think that's the most important part I'd like to get out of tonight, is if you ask the right question, you'll find the answer more quickly. And then how do I get an answer in 5 minutes? Is it possible? Can I achieve that in my regular visit in front of my patient? I think you can, but not always. But you can certainly do it for a few patients in a day. Students and residents as teachers, we've got a few residents here tonight. I'd like to introduce the concept that we should try and listen to our students and our residents as much as we try and teach them. They've got a lot to teach us and show us new ways. And I've had a conversation with a few people tonight about how, as much as I know why, but I know how I do something and why, when I treat something, what I need to treat. I'm not sure exactly always why I'm doing it. And so the residents often help me understand why, and I teach them what I do, and then it helps us both figure out why we're doing it. So what is evidence-based medicine? Anybody want to pipe up as to what they think evidence-based medicine is? It sounds like a dry phrase, but what do you think it is? Nobody?
Medicine based on studies that give different outcomes and under different conditions. The gold standard is your randomized, blinded, controlled trial, I guess.
Yeah. So your gold standards for different types of studies, and how you apply that to your patient in front of you, it might be different to the patient in the study. Anybody else?
It seems to be more focused on outcomes than markers.
Great. Yeah, so I'm not particularly interested in what my A1Cs are. I'm more interested in whether or not the patient is going to die from having a higher A1C, or is going to die from having a lower A1C in their heart rate and breaking their hip. Anybody else? So Martin Dawes is the UBC head for Health and Family Practice, and he says doing the right things to the right people at the right times. My personal favourite is patient-centred, evidence-informed medicine, so I don't necessarily have to follow the guidelines. I want to follow what my patient wishes. And then evidence-based clinical practice. So when I first started doing these talks, I really didn't feel like I was practicing evidence-based medicine very well, because I wasn't actually looking at all of the questions I wanted to ask, and I wasn't feeling like I was getting to the bottom of every clinical guideline. But by the end of this talk, hopefully you'll feel more comfortable that you're doing a lot of what evidence-based medicine is without actually knowing about it already. So this is a Venn diagram around what evidence-based medicine is. The most important two things, I think, is we're actually already doing 2/3 of evidence-based medicine as physicians. We're very quickly able to assess our patients' concerns, their values, their circumstances, and we're already showing, or I think we have a high level of clinical expertise to find out what the problem is, and we know about how to treat it. It's just we want to now try and make sure that we're getting the most available evidence in that treatment decision and communicating that available evidence and making a decision with our patients. So this, I'm sure you've all seen this pyramid diagram. This is the best one I could find, but you want to get the best evidence is at the top of the pyramid, and they tend to be the least numerous. The most numerous and the easiest to find, unfortunately, are usually the randomized controlled trials, which may show a benefit or may show a harm. And there's lots of conflicting studies down the bottom, and then you're tending to get more strength in quality and less numbers of papers, but also the papers have already been reviewed by a highly qualified research tech or an evidence-based medicine practitioner who reads hundreds of journals a day. So I'm not asking anybody to read studies, I just want us to try and access the information in a timely fashion and get to the top of that pyramid within a few minutes. But I think the most important thing isn't just accessing systematic reviews, it's accessing a quick way of finding the guideline and comparing that to the most recent evidence for a systematic review, for example. So the clinical expertise, what is that? We practicing our clinical skills and our acumen, being diagnosticians and trying to find out what the medical condition is the patient has, and learning from our past experience and background knowledge of managing that similar condition. So we all have that patient where we manage the condition really well, and then you see the next patient has a very similar condition, and you lay out the same treatment plan, and it doesn't quite go so well, and then you do that a few times and you realise that not everybody responds to the same treatment, but you find the average treatment that everybody responds to, and then try and find parts about the practice, parts about the patient, or areas of the patient's values and circumstances which you need to modify your treatment with. So, ability to rapidly identify patient values and circumstances is a big part of our clinical expertise. And then patient's values and circumstances, I think a really important one about values and circumstances of the patient is if they don't want to take something, I'm not going to damage my patient-doctor relationship by trying to force them to say, I want you to have your pneumo shot. Well, you don't have it, that's fine. But I'll talk with you about it a few more times before we really decide that we've been talking about why I think you should have it. And then, do they have, how much life expectancy do they have left? So if treatment could take 5 years to give the benefit, or 6 months to give the benefit, they don't have that life expectancy, there's no benefit to exposing them to the risk of that treatment. And then their unique preferences, concerns, and expectations. So I today had an MS, or he probably has MS patient today, who came in and he had 3 different consultations from 3 different physicians in the clinic in Victoria. And his most important concern was that the solar eclipse happened during the middle of his 45-minute session with his second practitioner. And that's therefore the reason that the second practitioner gave him completely different advice to the first and the third. And I thought that was fascinating. I mean, who knows, it could be right that the celestial alignment could make that difference in the way he was treated. But I think it was more because the second person was the resident and the third person was the neurologist. But yeah, you have to take that into account, and you don't want to shoot that person's ideas and concerns down the flanks. You just want to follow along with it. So I just did supporting constantly today. And then we'll do another video on evidence-based medicine, just to reiterate that. Reiterate the meanings of those 3 parts of the thing.
What is evidence-based medicine? Evidence-based medicine requires integration of the best research evidence with our clinical expertise and our patient's unique values and circumstances. This Venn diagram illustrates each of these components. The ordering of each of these components is important in most clinical decisions. Our current paradigm puts patients' preferences and actions as being the most important component in making a clinical decision, followed by the patient's clinical state and circumstances, and lastly by the research evidence. And finally, our clinical expertise tempers all these individual components to help us make a decision about what we should do for this individual patient. Let's look at each of these components individually. Patient's preferences. When 2 patients are confronting the same clinical decision, they are looking at the same information, weighing the same benefits and adverse effects, but often they come to 2 different decisions. This is because they've had different experiences in life. They have different values. They have different risk-taking. They may have different insurances and abilities to pay. Their family influences may be very different. Each one's individual willingness to take medications might be different. All this kind of stuff leads to a preference that an individual patient might have. Their actions are often different than their preferences. We all would like to be healthier. We'd like to exercise more, but we don't. We don't eat as good of a diet as we ought to. We might drink too much alcohol. We might smoke. So while we prefer to be healthy, sometimes our actions show that we do things different than what we prefer. The clinical state and circumstances. The clinical state is the patient's other comorbidities, the medications that they're on. All these things will influence decisions for other medical problems. Clinical circumstances tends to be our practice setting. Our decision on using some new technology will be very different if we're in a small rural setting versus an academic tertiary care medical center in a large city. The patients in an ICU, our clinical decision making is going to be different than if they're healthy and at a routine primary care visit. Finally, the research evidence. What we're talking about here is the most valid, so methodologically sound, and clinically relevant evidence we can find for this particular question that we have. Now, people who criticize evidence-based medicine often say that evidence-based medicine proponents only care about randomized controlled trials. Well, for many of the things we do, there are no randomized controlled trials. So we have to look for the best available evidence, which might be an observational study. It might be a bench research study only. It might be expert opinion only. The spirit of this is that we find the best available evidence. And once you become more skilled in evidence-based medicine, you'll actually be able to personalize that evidence. You'll be able to adapt a research study to your own individual patient who you're considering making a decision on. Many of our patients are sicker than patients who are enrolled in studies. And on average, the greater your risk of some outcome, the greater benefit you will receive from a therapy. If your patient is healthier than those in the study, on average, they tend to receive less benefit of an intervention than those patients in the study. And there are ways to adapt the study information to be more patient-specific and reflect this finding. And finally, our clinical expertise will tie this all together. We have to have good clinical skills. We have to be good diagnosticians and history takers. We have to make the right diagnosis. Doing all these other things and being skilled at finding a study and appraising it and assessing patient preferences doesn't really make a difference if we have the wrong diagnosis. So we have to be good doctors first. The other skills that our clinical expertise takes into account is being able to assess the patient's preferences, really taking into account where we're working and the patient's other comorbidities, and balancing all these things together into making a decision about what we should do, not just what we could do.
And that video is done by Terry Schoenfeld. He's referenced in the literature you have. So he does lots of little videos that are all sort of 4 or 5 minutes long as to what's sensitivity or what's NNT or what's the numbers needed to treat or numbers needed to harm. All of these little explanatory videos, he does a lot of them. So I haven't referenced all of them, but he's in the YouTube videos. You just follow one of the links on your Word document and you'll be able to find them. So I highly recommend watching them if you want to have a quick tip, 5 minutes. So this is quite a busy slide, and I don't really like showing it too much, but I just wanted to show you what we're going to cover in tonight. So the steps of evidence-based medicine without thinking is assessing our patients and coming up with a clinical problem, and then coming up with questions arising around the care of that patient in terms of the management of their condition. We then ask a right question, which I'll go through the PICO format with you if you've not heard that before. And that's very simple. That's part of that little cheat sheet, that laminated sheet you've got. I laminated it so you can scribble on it if you want to in your office and jot down notes. And then you acquire the evidence, which is not going to PubMed or going to a literature search engine. It's going to a pre-appraised evidence-based medicine site that I'll go through with you. And I don't normally recommend people appraise the evidence. That's not really what I'm wanting us to do, but it's probably a good idea to know the source of the pre-appraised literature base you're going to. So UpToDate versus Dynamo versus another way of accessing pre-appraised literature. So it's worth knowing how they're funded and their background a little bit. And then how you apply that evidence with the patient is the really important one, I think. You can explain the risk, if they understand the risk or the benefit or the cost and they still are willing to go with it, then you prescribe it for them or you treat them with it. And then after that, I think it's really important to evaluate how you're performing with that patient. How did that consult go? How do you feel they were left informed? And have the treatment they really wanted. The things I'm going to go through tonight is how you ask the question and then how you try and apply that to your patients. Does anybody have any questions so far? So why would I practice it? I think working smarter rather than harder. I don't want people to stay, and I don't want to stay late trying to research something at the end of my day. I'm enthusiastic about my job, but I'm also enthusiastic about my family and I want to be home. So how can I get it done in my regular office day and not be running late? And I'll show you how to do that. And it's not about critical appraisal. So a lot of people think that evidence-based medicine is reading the paper and trying to critically appraise the authors. It's not about that at all. It's just trying to use the right sites and using a variety of sources. I think improved patient outcomes are important. I feel more comfortable now than I did 5 years ago not doing things, which I think is really important, not prescribing that antihypertensive or not prescribing the extra hypoglycemic agent because I feel that they don't need it. And then that nagging feeling of how do I know that I'm doing the right thing for a patient? I think hopefully that practicing evidence-based medicine makes that feeling go away from me a bit more. And then becoming more comfortable while I practice evidence-based medicine again, becoming more comfortable with new ideas or new sources of learning like kids and our patients. So I often explain to my residents, if I have a patient with a new and complex medical condition, I will follow them much more closely than perhaps they need to see me, because I'll learn as much from them as I'll be able to help them in their course of their treatment. So a good example, I have a recent patient who was diagnosed with acromegaly, and he was diagnosed after a pituitary tumor bleed, and he came to see me, and we had a sort of long talk about what it means, and he then became completely hypopituitary and hyperpituitarism, and he had lots of different specialists involved, all of which probably knew a lot more about this than I did. So I honestly came out to the patient and said, hey, I'd like to see you every week or every 2 weeks to make sure that we're not dropping any balls and not letting any spinning plates fall. But also, I'd really like you to teach me what all the specialists say, because what's in the letter isn't always what the specialist tells the patient. So I usually will see them more often in new diagnosis that I haven't seen before. We had a rheumatology patient, Christine, right, a couple of days ago. She was 30, and she's riddled with issues, but she's highly functioning. I want to learn how I can make my new rheumatoid patients stay as highly functioning as she is. And her trick, what worked for her. So yes, we're going to see her more often than we would normally, because she's so well. We don't need to see her that often, but I'd like to see her more often to help her teach me. And then current practice. So this is David Slawson's evidence-based medicine practitioner who did talk around proficiency and what influences current treatments at the moment. I thought this was fascinating. So the 3 things that influence most, if not all, clinical decisions with regard to medications. Does anybody have any guesses as to what they were? So 3 main things that influence the prescription or non-prescription of medication. With regard to the patients in front of you, why am I likely to give that patient that drug?
Patient's preference.
Patient's preference, yeah, perfect.
Symptom management.
I hope so, but that wasn't one of them.
Diagnosis.
Sorry?
The diagnosis.
Yeah, that is important, but that isn't actually, I mean, once you've made the diagnosis, and once you've come up with a treatment plan for the patient,
For that, the patient can afford.
Yeah, affordability is a really important point, but that isn't the reason the patient gets prescribed.
The expected guidelines that you're expected to follow.
Yep, guidelines would be one of the reasons I prescribe. I would prescribe it, but that wasn't one of the 3.
What's covered by pharmacare?
Well, here locally in BC, but this was a sort of global talk. And actually, I thought it was quite fascinating. Patient requests is almost 40% of the time a patient walks in and says, I want that Lipitor because I saw it on the advert. Or Dr. Oz says I should take my antihypertensive at night instead of in the morning. Or Oprah's new lipid cholesterol lowering pill is much better than yours, can I take it please? So most of the time we actually would respond to that. Pharmaceutical recommendations, so prescriptions for drugs would go up significantly after a pharmaceutical rep would visit clinics, and I thought that was quite interesting. And there was a particular medication which was suggested that it wasn't effective. Doxazosin wasn't effective for hypertension, and the reps in North America stopped advertising it, and the reps in the UK continued to advertise it, and the UK prescriptions continued to climb, and the US prescriptions completely declined. After they weren't advertised, they suddenly fell off people's radar, and they stopped being prescribed. That was interesting. And then local expert-based continuing medical education sessions. So those are the 3. Keeping up to date is hard, I think. How many questions do we come up with in a day? If you add up how many questions you come up with for an inpatient, the average is about 5 times per inpatient per day. There's a clinical question we'd like to answer. 2 in every 3 outpatients come up with a clinical question for us. So if you add that up, that would be easily 25 or 30 questions a day for each of us. And what's the difficulty with the traditional sources? I put my textbook down for medicine that cost me hundreds of dollars when I graduated medical school, and I put it down after the end of my first year residency, and I didn't do that again. I did everything online after that. So out-of-date textbooks. The not wrong source, but the source is wrong for my patient, so the expert or consensus opinion of the cardiologist that spends all day doing primary coronary interventions for 50-somethings. I can't really apply his guideline recommendations to 80-somethings. And then ineffective lectures, so lectures where you're just teaching somebody by rote all the different management options. It's just too difficult to get to see those, and too difficult to keep all that information in. And then the overwhelming level of volume of medical journals. I think the quote for my favourite quote is, if you tried a page a minute to read every journal that's published in one day, it would take you something like 6 years to read all of the journals published, all of the medical literature published in one day. And so the knowing and not knowing concepts, I like to feel that I would like to know, I'd like to feel comfortable not knowing the answer of my patients. That has to be handled. And there's knowing, which is cognitive resonance. I know, I feel better about knowing, I feel great, I'm treating you, I like knowing, I like knowing. Not knowing is, I don't feel so happy about not knowing, I feel uncomfortable, and I prefer not to let my patients see that I don't know what the answer is. And then not knowing you don't know is the undisturbed ignorance. So that's I have no idea that I am treating this patient incorrectly, and I'm going to carry on, and I don't feel bad about it whatsoever. And then all through our education, we're sort of rewarded for knowing the answer, but nobody really rewards us for saying, actually, I have no idea, and I'm going to go look that up. And I think that should be, we should feel more comfortable not knowing the answer to everything, because I don't know the answer to everything. My patient that comes in with a homeopathic remedy, I'm quite unable to counsel them about the effectiveness or the possible side effects. No, I'm not able to counsel the effectiveness all the time, but I can counsel them about maybe side effects, or I can help them make a decision themselves, but I can't inform my decision for them. But feel comfortable about saying, I have no idea if that prostate X vitamin is going to help you with your PTH, but no, if I was you, I probably would do this. And also, open to learning from all of our sources, including residents and patients. So turning that not knowing negative feeling into the positive space. So the negative feeling of I don't know into the positive feeling of let's build a question around that. I don't do it during that visit often. I'll bring that patient back if I don't know, and I'll say, oh, you know what, I really would like to find out about this. I'll phone the specialist, or I'll do some literature research, and in the meantime we'll do this, and we'll see you back, or I'll call you next week, or I'll all those vocal billings that we can do. So don't plan ahead and try and not make it part of your regular visit. You can always bring them back. And then avoiding maladaptive. So trying to hide our deficits, or reacting with aggression or fear if somebody comes with your naturopathic remedy and you're refusing the sort of modern medicine techniques. I think it's important to keep that doctor-patient relationship. One of my patients who I came to the Wharton Clinic recently, I took him on as a patient. He had explored, he'd been diagnosed with bladder cancer from a cystoscopy, and he was told to come back for repeat cystoscopies 2 years ago. And he went to a homeopathic remedy doctor who informed him that absolutely we can cure you with your bladder cancer. And he came to see me a year later with quite acute prostatitis, and he told me the history about his bladder cancer, and he'd been passing these bits in his urine for the last 6-8 months. And his ultrasound showed that it completely replaced the inside of the bladder tumor. But we explored why the homeopathic remedy wasn't probably a good idea, and he still mentions about whether he should be taking marijuana or whether he should be taking some sort of homeopathic remedy, but I try and handle that as gently as I can whilst encouraging him, well, I still want to do that cystoscopy. So try and maintain that doctor-patient relationship, otherwise he'll disappear and not see us again in a couple of years. So are we up to date? I think my background knowledge, I know about certain medical conditions, is dropping. So background knowledge is what is the medical condition, or what is the pathophysiology of the medical condition. But my management skills are increasing, so I know a lot about the most up-to-date treatment of hypertension or congestive heart failure. So as we get farther into our careers, we know more about the management and less about the cause of a medical condition. And asking questions can be frustrating. How can I do it, and how can I do it quickly? I'm going to show you that in a minute. So this is the slide I like to show about background knowledge. So when we leave medical school, we have lots of background knowledge, and I have hardly any idea about when I should prescribe Tylenol. And now I'm hopefully better at prescribing Tylenol, and I might be comfortable prescribing more aggressive medications, and more intense medications that feel comfortable managing it because I may have prescribed it or saw advice about it before. And so I think the resident's probably more to the right, but I hope to think that there's still lots of foreground questions for most of us. Foreground questions is really where evidence-based medicine comes in. So I know the condition, I've diagnosed the patient. How can I make sure that I'm applying the best evidence in that patient for that condition? And the PUSDR, I'll cover this very quickly. PUSDA stands for patient population. So how old is my patient? What's the socioeconomic status? What can they afford? What can they not afford? What's the intervention I'm looking for? Is it a treatment? Is it a non-treatment? What's the comparator? So if I compare a blood pressure medication to a blood pressure medication or a blood pressure medication to nothing. And what are the outcomes? I think the most important thing is the outcomes. What is the outcome I'm looking at? Am I looking at cardiac death, which is a big deal, or am I looking at an MI which may cause morbidity, but the chances are lower and there's an increased risk of harm from that medication? And then over time, time is not just how long does it take to be effective, how long is it effective for? When should I stop it? So a good example of, sorry this is a little bit small, but a good example of a well-built clinical question, this is from a book that's referenced in your sheets. So a good example of a background question would be, what causes a pleural effusion, or how does heart failure cause pleural effusion? A good foreground question would be, in adults with heart failure with a reduced systolic function, would adding the implantation of an electronic resynchronization device to standard therapy reduce morbidity and or mortality enough over 3 to 5 years to be worth the potential benefits, potential additional after effects and costs? So that's you can see that's quite a long-winded question, but the most important thing is coming up with a good question so we can find the answer to it. What are the other factors? We mentioned a few factors already about the things that could be barriers to patients receiving treatments. So what's the guideline? Am I comfortable telling the patient what the guideline is, what the most recent evidence is? Is there a conflict there between the most recent evidence and the out-of-date guideline? What's locally available? If I can't do liquid-based cytologies for my PAPs, I can't offer it. If I can't offer a treatment for something, we were talking about Dopplers earlier today. If I can't offer Dopplers from arterial Dopplers for my patients, so how do I manage that patient with potential arterial and venous insufficiency when I want to use compression stopping? What's reasonable for that patient? Are they going to be able to put those compression stockings on? What's cost effective? How much does it cost? Somebody can they afford it? Are they going to put them on? Do they like them or not? Most of the time they don't. And what's the harms to the patient for that treatment? And are we looking at the right thing? Are we making their legs smaller? Or are we making them get out of bed and do more? And applying it in real life, this is again, I don't tend to do more than about half an hour of reading. Apart from my resident feedback reviews, I do resident feedbacks with my residents every day. And we'll usually look at something in there, but usually I'll do about half an hour reading a week around an evidence-based topic that I haven't known much about. So I don't do a lot of it, and I spend a few seconds through patients, and I'll phone a lot of specialists during the day to try to more about conditions, but it's an incremental process, like I mentioned before, about acromegaly. I didn't learn everything about hyperparathyroidism in the first visit. I learned it over 6 or 7 visits. And then the variations in practice, so the coffee table conversation about cholesterols annually. Oh, my cholesterol's dropped by 4 points. I have an annual cholesterol every year, and my patient comes and sees me and says, why don't I get an annual cholesterol every year? Don't you care, doctor? And trying to be aware that that's going to be a difference. And then the difference between the specialist and our practice, so that cardiologist that prescribes 80 milligrams of lipitor to an 80-year-old that actually happened last year. How do I say that's maybe not such a great idea, or the cardiologist is very good, but we should look at this in context of how beneficial it is if it's keeping you on the couch because your muscles are too much. And then jotting down notes in a short-term format. So that laminated sheet, I'd recommend you try and keep that somewhere close so that you can, if you have a question, you can write it down in a quick format. For example, over 18, treatment with cholesterol with a statin to prevent heart events or cardiac death. Send yourself a note within your EMR if you're able to. I tend to do that a couple of times a week. And then if you dictate, then you can even dictate a note to yourself to be given to you by your typist at the end of the day. So some of the terminology, just to reinforce some of the things that we're using, is part of that.
And then I went, for example, 2 months later to Therapeutic Initiative,
Yes.
the conference, and it was completely opposite.
Yes.
So we learned from one BBC professors, that you have to use that. And of course, and Therapeutic Initiative said, no way, no, the numbers need to do this, so this, and this is not, it's completely wrong.
Yeah.
And, it's as a GP, it's we are learning all our lives. So it's just that it's so confusing. I wish we had, I used to be in Britain as well, so we had MIMS, which is very slim therapeutic index, which was terrific. There's no proprietary drugs. Here is CPS, which is like this. And we are bombarded with all the confusing data. And to try to find the evidence-based medicine during the patient consultation, if you try to get your iPhone and try to do update and see what your condition is, the patient either leaves you and says, this doctor doesn't know anything, he just has to check all the time and he will never come back to you, or, I'm just...
Yeah, it's difficult. It is difficult. And actually, a couple of our friends...
Yes, and then I see, radio doctors sometimes comments, not about me because I'm retired, so they don't comment on me, but it's just, some younger doctors get comments from patients. This doctor doesn't know anything because...
Well, I would say, there's always going to be that patient who, if you don't have a good doctor-patient relationship with that visit, and you're spending most of the time looking at a computer screen that they think is Google, then that's probably, they're not,
most of the
this is not
patients
going to
don't
leave
like
you.
when you look at the computer and start trying to find
Yeah, that's a
something.
constant battle.
Yes.
But yeah, I'm glad you put up about the therapeutics initiative, because they are
But there are now
very, very
no
one-sided. But I would say it's a bit like reading the newspaper. So if you, in the UK, are sort of more used to the political leanings of the UK newspapers. But if you read the newspaper, The Guardian was the sort of relatively left-wing newspaper. The Independent was the relatively middle newspaper, and then the Mail and the Times were completely right-wing conservative. And it's a bit like that. You need to. I don't read all the news and the Mail and believe all of it. I have a bit of a BS filter to filter out the stuff that I think is politicized. And it's the same with this. I think you need to be aware that there is something other than guidelines. And you need to be aware that there are people who still benefit from statins, much to
So
change
how much
the
we should believe
program.
these guidelines?
Right.
How much we should believe the guidelines?
Well, that's a good. So that you need to know a little bit about how the guidelines are formed, and you need to be a little bit sort of critical of everything. So I would say maintain a high level of cynicism for everything, and be curious to learn every source. But I don't think I would ever change my practice based on one medical learning, unless it's been corroborated by other medicine. So if I've heard from a physician that it's a good thing to do this, will I change my practice based on that? Probably not. But if I heard from a physician and I looked into it a bit, and a couple of the websites that I'm going to show you corroborated that, or I communicated with the patient and said, what, I've heard this from one physician, and theoretically it kind of makes sense to me, but I'm not sure about the strength of the quality of the evidence behind it. How about we, you look it up on the internet, I look it up on my medical resource sites, and we'll make a decision together next time. Or you communicate, I don't know about the quality of this, but it's likely not to be harmful. You can make a decision with your patient there and then. But there are lots of examples where, like the American Cardiovascular Society guidelines, everybody with a cardiovascular risk of greater than 7.5% will be given a statin, whereas in the Therapeutics Initiative, almost nobody gets a statin, including the high-risk diabetics. And by the time you're 75, everybody starts coming off as that. I think there has to be some give and take about. And you communicate with your patients. If I've got 80-year-old patients on statins, sure I have. And I've also got most of my 80-year-old patients off their cholesterol tablets because I don't feel that there's a huge amount of benefit behind them. And I discuss that with the patient and make the decision together. Usually the patients are highly enthusiastic to use it.
Do most of the guidelines list their funding sources?
Great question. So Dynamed does show, the Dynamed website does usually show the source of the guideline and the quality of the evidence. But it doesn't always show the funding, sometimes it does. But like up to date, I actually found it quite difficult to find how up to date was funded and how Dynamed is funded. And it's not funded by our subscriptions, not by a long ways. But up to date it's funded mostly by US secondary care facilities and quite a lot by pharmaceutical industry.
Sorry,
I think like
who funds it?
US secondary treatment services and pharmaceutical companies. There's a lot behind it. Yeah.
yeah.
But that,
Makes you
as long
wonder.
as you know that there is some pharma industry influence, you would take it as a means of just like you go to a local CME session that's funded by Viagra, and suddenly Viagra sort of rep comes up, and it's nowadays the control of the drug rep's influence on those CME meetings is good, but it used to be that Viagra was all over the presentation and all over the table when you were listening to things, but it's still there. You still have that influence of drug rep CME sessions, but you'd hopefully be able to realise that the drug rep is sell something, and we're not in the business of selling medicine, we're in the business of trying to do the best thing for our patients. And if it's $25, I think we had a new meningitis vaccine drug rep come around recently, and that wasn't a great experience. He was really sort of, you've got to sell it to the patients. If they get this, they're going to be really sick. And it's, there was 1 in 4,000 people got it, and it costs $300 per vaccine, and you have to vaccinate about 400 people. So if you think about how many people you have to vaccinate to save one episode of a relatively mild version of meningitis that recovers spontaneously. And he was saying everybody should definitely have it. So you have to take that. As long as you're able to get to the evidence behind or the quality of the treatment and get to those numbers. If you ask a drug rep what the NNT is for something and they don't know, then that should tell you something about the quality of the evidence behind their treatment. Yeah.
When you quote like NNT and NNH, is it based on like an annual rate, or is it based on expected duration of treatment? Or?
Great. So the question was, if you have an NNT or an NNH, what length of time does that NNT apply for, or that number needed to treat apply for? So usually it would be contextual. So you'll have an NNT, and I can show you if you like, that there's an NNT for a cholesterol a patient given a statin, being given that statin for 10 years versus being given that statin for 20 years. And the NNT, if it doesn't change much in that time, then it's probably not going to be beneficial for the second 20 years, for the second 10 years. If it does change quite a bit, then you're more likely to get benefit from giving them longer prescriptions. But yeah, good question. So normally it doesn't. It's just, I expect the treatment and I give the treatment and that's it. And there isn't a lot of longitudinal follow-up for things like benign prostatic hypertrophy, the alpha reductase treatment. How many people need to be treated to get the benefit, how many people were harmed. There's, looking at the outcomes of what the harm was, looking at the outcomes of what the benefit was, it's usually over a period of about 18 months, but you have no idea how long after that they get benefit, or whether they get sustained benefit or not. Does anybody have any other questions? So this is a little bit of a case study bit. So this is, I started this with one of my residents 2 years ago, and we sort of had a couple of patients where we were getting results back, lots of results back for a patient, and we decided how much does that actually cost the health system? And so this is how it started. How much are those lab tests costing? And how much value, clinical value, are they providing us as clinicians? And is it worth ordering that test, or does it just lead to more questions? So this is our first case study. A 20-year-old man who had been ill for some time, and he'd been ill for about a month, I think. But he was complaining of generalized fatigue, wasn't feeling very well. And at the first visit, a colleague physician ordered this list of tests. So what does everybody think about this? This is a relatively extreme example that we pulled up for the resident. which of those tests would you have ordered, which of these tests would you have not have ordered? And there wasn't any documentation in the notes as to symptoms. I'm sure he did go through a list of symptoms, but a lot of these tests could have been missed off if they didn't have symptoms. So sorry?
That's a CBC, the simple one, CBC or
Yeah.
what's on there? CBC.
TSE.
Electrolytes and creatinine, maybe.
See that there's mono, hematology profile, throat culture, an ACR, a lipase, an A1C, a B12, a reticulocyte count, calcium, ferritin, a urine micro and macro, a TSH and a free T4, all 6 of the liver function enzymes, and a urea tract electrolytes. So I'll just, I'm sorry it's not easy to see, but this list of tests cost $410. And that $410, if you did that on 5 or 6 patients a week, that would be the equivalent of nearly a knee replacement in medical cost with your visit. And all of the subsequent visits for all things which were falsely abnormal. So they have a slightly high bilirubin, well, who cares, it's 20. And whether they have a ferritin which is normal or not, their CBC is normal, and their fatigue results within a month, they probably need to treat things. So the thing that surprised me the most was the cost of the albumin creatinine ratio was about $27. A B12 test was $20 or $29. Free T4 and TSH was between them $44. And a ferritin was $35. So I'm surprised that actually the government isn't trying to restrict those tests a bit more. Why, if the CBC is normal, you need clinical indication for ordering ferritin. And then the second case study is a 55-year-old man who comes in for a long visit because he wants a health check. He hasn't seen us for 10 years. His last cholesterol ratio was 5.5. His last fasting blood glucose was 5. He's a smoker, has been for a long time. He has benign prostate enlargement with lower urinary tract symptoms. And he's not seen you since that last visit, and he's gained 50 pounds. So what would you do if you had this patient come and see you? Would you reorder the cholesterols? Do you have a set of hands? Who would order a cholesterol?
It takes family history.
Well, it depends if you ever had one. I mean, haven't you even done, have you
So
done
the cholesterol
physical
ratio
yet?
was 5.5 last time, 10 years ago.
But where's your physical? You'd start probably the physical somewhere there.
Yeah, you would. Yeah. So yeah, I mean, this patient has no symptoms of any significance. And he's a normal physical exam. Sorry, I should have probably said that. So, would you order a cholesterol? Would you order an A1C? I left it at just A1C because now the clinical guidelines for diabetes allows you to order an A1C, and that's considered a screening test for diabetes. So if it's greater than 5.5, 5.5 to 6 is considered increased risk of issues. 6 to 6.5 is investigate for impaired fasting glucose, or probably has impaired fasting glucose, and 6.5 plus is one of the diagnostic criteria for diabetes. And then urinalysis, would I order urinalysis for this as a screening? Probably not. Rectal exam in a 55-year-old, hasn't seen you for 10 years, you're probably not going to see him again, he's got BPH. A fit test, would you do a fit test? Does he qualify for a physical? These were all questions the resident and I went through. And I think that this person does qualify for a physical this time around, from a clinical perspective. I would do the fit test. Would I order a PSA? Well, when I did the research on this, PSA test is about $35. It's $30 to the patient if you don't have a medical indication that you probably would qualify. And I looked into this, and the Canadian Task Force came up with a guideline for PSA order recommending absolutely nobody gets PSA tests anymore, regardless of whether they have urinary symptoms, unless they have been diagnosed with prostate cancer. But I thought that was quite interesting. But the local CME talk that I last went to was everybody should be getting PSA tests who has BPH, and they should be monitored every 6 months. So there's how many people do we see with prostate cancer versus how many people does the urologist see with prostate cancer, and their guidelines and management will be different. And then a rectal exam, I would do a rectal exam. Probably wouldn't, there's not much benefit in doing a urinalysis. And I'd do an A1C for sure, because if he's gained 50 pounds, it'd be worthwhile encouraging him if he has a pre-diabetes or diabetic condition. But I probably wouldn't have done his cholesterol again, because he has to sit in the lab he has to fast overnight, and he has to sit in the lab for 2 hours. If anybody's sat in a fasting lab, it's usually an hour and a half or hour to get seen if you're 5 minutes after 7:30. And it probably has changed, but unless his clinical metabolism has changed, doesn't need to become diabetic, it's not going to have changed significantly enough for him to be prescribing a statin, and therefore I don't think it's worthwhile checking it. But that's my personal opinion, and I'll communicate that with him. Sometimes I might check it to try and use that as a carrot to say, hey, your cholesterol's really high this time. Maybe we should wait. But a lot of the time that actually might switch off the 55-year-old guy and say, oh, my doc's just going on about my cholesterol again. So, what does everybody think about that? Going through that. We probably would all practice slightly differently, and we would all practice slightly differently based on the patients in front of us and how often we're going to see them again. But I would encourage us to try and think, do we need to order all the tests? Are they all clinically valuable? If we ordered all of those tests, without the visit, it would have been in the region of $100. And then the visit on top of that. So, and then that same guy, what interventions will we be able to do for him? What are the useful interventions? Does he need a shingles vaccine? He would qualify for the shingles vaccine for the 50.
No.
Does he need an pneumonia shot? Does he need a tetanus shot?
Tetanus, yes.
Does he need a weight loss prescription? Which is the most important? What does everybody think?
I think that preservation is not.
Yeah, number one is the stopping smoking. Yeah. Shingles vaccine, how effective is it? I think it took me a while to figure out the evidence and communicate to my patients effectively about shingles vaccines, but now I've pretty much got it down pat after the 100th consultation. But there isn't actually a whole bunch of benefit behind the shingles vaccine. I need to vaccinate 165 people his age before I move up one outbreak of shingles. But otherwise, it would have happened if they hadn't been vaccinated. And it costs $185. So, if you can't afford it, I would recommend it to him. If he's got nothing but coverage and he wants to do something about it, and he realizes that it's not that effective, then I would prescribe it for him. As long as he knows that if he gets shingles, it's not because we didn't give him the right vaccine. So, and then the pneumonia vaccine, how beneficial is it? It's probably worthwhile, but because we vaccinate kids with it now, but it's not an absolute necessity. If he's a contractor or something and he's going to get scratched, he probably will do for a pendant tetanus. But the most important is the weight loss and the smoking cessation. So this is a hyperlink for tools for practice. I got the numbers needed to retrieve from two different places. Dynamed, and then Tools for Practice, which is also one of the links. I'm going to show you on this link. Good work. So this is a. Oh, it's on this one. I can't drag it across, unfortunately, I'm not going to be able to show you. But there's a leaflet in Tools for Practice that's a 2-pager that I tend to print to my patients. Sorry?
Do you want me to do it?
Yeah, there's a 2-pager around the Tools for Practice is 50-something or 50 to 60-something, how many people do I need to vaccinate? Some screening and 500 exams.
Because
Well,
most of
and
them are not,
physical-
insured.
Well, the billing and the treatment is two different things. So we get paid for a pap test, but there's two sides of that gynecology exam. There's the 20-something who doesn't need a pap test until they're 25. If you know about the most recent Canadian Task Force guidelines, the girls that have been HPV vaccinated, who are sexually active, regardless of how long they've been sexually active, the recommendations they probably don't need a pap test until they're 25. Whereas the current BC guidelines is within 3 years of sexual activity or the age of 21, whichever one comes first. So if you've got that 20-something, and I do the sexual health clinic in downtown in the evenings, and if you've got that 20-something who's coming in for their birth control refill, and you're sort of, oh, maybe we should do a pap test. If you do a pap test, that person has their pap test and gets recalled 4 more times before they get to 25, and within the next 2 years they'll probably bring out the BC guidelines adaptation that says, actually, you don't need a pap test till 25. So I would encourage people to discuss, and I don't tell my patients that's the rules. I tell my patients, well, there's two schools of thought. One person will go to the BC guidelines and recommend that person gets a screening, but there is some more evidence that's more up to date and is high quality, that's Canadian-wide and still Canadian, but it's not provincial, that suggests you might not need a PAP test till you're 25. If you wish, we can do the exam. If you don't wish to do the exam, that's absolutely fine with me. I don't have a recommendation either way.
But do you do swabs, no?
I do so the sensitivity and specificity of the urine test, the chlamydia and gonorrhea, is equally as good as
So
the
it's
swab.
just
I just do the urine together. But if they have symptoms, so that guideline isn't for people who don't have any symptoms. So if the girl that has irregular breaks and bleeding, that's probably worth having a whole look. Whether you do a PAP test or not is different. But I would usually do a bimanual exam on all of my young patients because there's often I ask a sexual history on everybody and you'll be surprised how many people don't pipe up about their sexual symptoms. So I'll do a bimanual exam on everybody who's sexually active, and 50 to 70. I've stopped doing it as much if I offer the patients if they want to do it. So once they stop having a PAP test, then I won't do it. But I explain why. And if they want to have it done, it's fine. If they want to have a breast exam, as long as they understand that the breast exam is more likely to lead to interventions and investigations and perhaps worry and harm for the patient than it is to find something. As long as they understand that, I'm quite comfortable exposing. And then to answer your question about bimanual exam, who else has changed their practice based on that, or who would change their practice based on that? Every patient who they see, would they stop doing bimanual exams or would they continue?
It's hard because you've done thousands of PAP tests and bimanual exams, and you've seen maybe 4 or 5 people with ovarian cancer and cervical cancer. It's really hard to take that out of your head.
Yeah.
And that's your own experience, and it's this big, huge flashing red light that you better do something.
And nobody will thank you
Yeah.
for not doing it once they have their ovarian
Yeah,
cancer.
it's
Or
hard
an
to
idiot.
ignore your own experience.
It's true. Yeah. But that ovarian cancer patient was exposed to 10 or 15 physicians in their treatment probably. And so all of us remember an ovarian cancer patient, which actually the prevalence is pretty high, but the prevalence is pretty high regardless of whether you do the screening. It doesn't make a difference. That's the most important bit. As long as you educate the patient about the fact that this screening test is probably not helpful, but if you want to do it. And I think there's a TED talk by a physician who talked about the lost art of medicine and how hands-on patients is actually really important and how you can have the healing touch. He's sort of quite holistic, but if you do a pelvic exam or if you do an examination and you're putting your hands on the patient, that patient leaves the room feeling that they've had treatment and they feel that they've been looked after and they feel they have a relationship with someone, a connection. And so there's a therapeutic benefit of that. And as a resident, I did dissections. My medical school, I was the last person in my, the last cohort of residents of medical students that was going to do dissection. I would be really sad to have not dissected the cadaver because I've learned an awful lot about anatomy. And same with bimanuals. If my residents aren't all doing bimanuals, then I think there will be some educational opportunity lost. So again, it goes back to you don't necessarily have to follow the guidelines, and that acromegaly patient doesn't necessarily need to see me again, but I bring them back because they educate me. And I might well ask the patients if it's okay. It's not recommended, but if you don't mind from my learning, can I do a bimanual exam for the residents? I would think that's completely appropriate. So we have a patient today, Christiane, who had a whole bunch of negothian cysts. She'd been treated for abnormal cervical change in her late 55. She had a whole bunch of negothian cysts on her exam, and I've been watching that abnormal cervix for 4 years and being sort of referring her and getting advice and doing ultrasounds and exposing her to all these investigations. She's very fed up, but we're trying to reassure ourselves that she doesn't have anything. And then again, I looked at her cervix today and it's completely abnormal looking, but it's just that's the appearance of her cervix. Proof that that's not pathological. And I showed you today. It's kind of important to realise that we have to feel comfortable being a little out of our comfort zone. So wellness square education, educating our patients about the risks of doing something and not doing something. And I find it comforting to remind myself actually it's harmful to do something a lot of the time. It's just as harmful to do something as it is to do nothing. But this drive a change in everybody's practice overnight. It's a gradual progression to being open to receive other news sources and reading more than one newspaper and realizing that there's influences in all of the things we're doing. There's no one side up to date. I try and ask my residents not to look up to date when they come talk to me about their visiting because I want them to explore other options. And up to date is great for secondary care in the US, but it's not applicable to everybody. So, does anybody have any questions about that discussion? I know I'm not being prescriptive, and I know I don't have the answers to everything. I just try and educate my patients about what I do and don't know, and we make a decision together. So the most cost-effective thing for this patient is the smoking cessation. And the shingle shots are $180. The pneumonia shot and tetanus shots are actually about $35 each from the public health. They're not particularly costly interventions. And the next patient's 85. She's a female nursing home patient. She's come into my practice for the first time. She's got a cholesterol ratio of 2, had fasting blood glucose of 6 10 years ago. She's a smoker. She's on a whole bunch of meds, including a statin. She has a history of what we think is chronic kidney disease, GFR's 50-something, and she has hypertension, Parkinson's, and COPD. So there's a list of investigations, I'll read them through. The rest will be this small, but would you do a cholesterol on this patient? Would you stop their statin? Would you keep their statin? What about the pneumonia and tetanus patient in this patient? And would you do an A1C or a fasting glucose? Would you do a fit test on this patient? Mammograms, end of life, polypharmacy review. Is that patient qualifying for a physical? Anybody have any comments? Well, I think this patient qualifies for a physical, absolutely. And I think this patient, most importantly, I'd like to talk to them about their medications because they don't sound like they're going downhill in their functioning and their life expectancy is less than 10 years. So, no, I wouldn't do a cholesterol and I probably would stop their statin. But again, I'm not prescriptive. If they want to stay on it and they know the benefits and the risks and they have that ability to make that decision, they're adamant, I'm not going to destroy the doctor-patient relationship by stopping it. Well, I probably wouldn't give either of the other vaccines. I'd probably give them, I might give them the pneumonia shot, but I usually give them the flu shot every year. I'm not sure that I'd want to do more diabetic monitoring. They've reached age 5 and their blood sugar was okay-ish 10 years ago. How much benefit is there in doing them a fasting glucose? Would I do a fit test or a mammogram? There's just not enough benefit in this patient to do it because she's past her average life expectancy and those things are more likely to be harmed. But I would do the end of life on the polypharmacy review. So a study about polypharmacy showed that on average 40% of the patients, 40% of the medications that patients have receiving more than 5 medications can be stopped with absolutely no clinical change for that patient in terms of their blood pressure or their functioning. That's kind of interesting. And that's just another cost and stuff. And then a comparative physical for this patient. He's 82. He's a working real estate agent. He's highly functioning, plays golf every week, and he wants his cholesterol check. And this is actually one of my patients. He came in every year asking for a cholesterol check for 5 years, and every year I would have the same conversation about whether or not there would be benefit. He's that man that has that coffee table conversation about his friend's cholesterol dropping a couple of points every year. His cholesterol ratio was 3.5 4 years ago. And this is the 5th time he came to see me. And his fasting glucose was 5.5 4 years ago. He's a non-smoker, his BMI is 28, so not bad. He's not on any medications, he has absolutely no active medical problems, and he usually sees me once or twice a year with no family history of note. So who would I do a cholesterol? Would I prescribe that statin for them? Would I have a conversation with them about his heart disease risk? All the vaccines and things, I'll just go through that quickly again. I wouldn't be doing his cholesterol, but actually in the end I did order the cholesterol for that patient to try and preserve the doctor-patient relationship, and it hasn't changed. I wouldn't be ordering a statin, and I explain that to him every time. What are we going to do with the results? If I'm ordering a test, what am I expecting the test to show, or what am I going to do with the results? If I'm not doing anything with the test results, and I'm expecting it to be normal, then I'm either ruling something in, or I'm not getting any value out of it. So. And then all the other things I don't know that they're really that beneficial. He doesn't really qualify for a physical every year, because he hasn't got any medical conditions. this is more for the resident. And what's its heart disease risk? It's the lowest it can be in this age group, which is probably still 15 to 20%. But cholesterol tests are not going to make any difference to that, for cholesterol prescriptions. And then this is the, it's a shame I can't show you the studies, but in 80-year-old patients, regardless of their medical morbidity, what's their blood pressure targets and what's our A1C targets for those patients? And these both came out in the last 12 months. So, but I've been trying to adhere to this sort of practice a bit longer than that. But the average 80-year-old, if they're having an A1C of 6.7 or 6.8, they're probably having unrecognized hypos. And so if they're on medications to drop that blood sugar, they're probably having hypos, unless they're just on that. So I usually recommend my patients to back off their insulin and let them hang around 7.5 to 8, and even up to 8.5, I probably wouldn't be adjusting the medication. So an A1C of 8.5 is an average blood sugar of between 9 and 10. And then systolic blood pressure, I'd be happy with it below 150 in the office. And I always use BP True. I don't know if you all use that. It's a blood pressure measurement every 30 seconds for five or six measurements. And often my blood pressure is 160 or 170, and then I do the BP True and it's an average of 130 something. So we always overtreat and overdiagnose blood pressure. And then, this is really quite difficult to see, but I'll quickly run through this. So a patient comes in for a physical who's 20 years old, and this was just trying to prompt a discussion about whether or not they need a pap test. She's had the HPV vaccine, she has sporadic use of birth control, she's not sure of the last period. Would we be doing a pap test? Would we be doing a pelvic exam if he doesn't have any symptoms? Probably not. Would I do swabs? I always do the trich-vagina chronic swab, which is the trichomonas, candida, or yeast, and bacterial vaginosis swab. And I diagnose lots of people with it. But I don't treat everybody with bacterial vaginosis. I phone them all up and say, hey, you've got this, and this is what it is, and if you get symptoms, that's probably what it is. If you want to treat it, you can. If you don't want to treat it, you don't have to. So, but chlamydia, trichomonas, those things are probably we should treat those. So, would I do a pregnancy test? Yes, I do a pregnancy test, and I would always offer an STS screen to all of my 20-somethings. But as I said, the urine test is just as sensitive as the swabs. And then this is just an example of how can I reduce costs in my practice. Try and avoid set ordering. And the cost isn't just the cost of the test, it's the cost of the visit for the patient sitting in the lab, waiting for their fasting glucose when they don't need to, and then waiting in the clinic to see you again for the results. Try and retrieve any previous investigations from other clinics. So often, ANA or ANCHOR is, you only do that once in a patient's lifetime. And vaccines, they often forget that they've had vaccines or they've had an echocardiogram before, and they're still clinically relevant for decades. And then smart ordering of tests. So I won't often order a urine culture, I'll order a urine analysis if I'm doing a screening. If that urine analysis is positive, then maybe not a culture. Or if I do a TSH, I won't order the TSH and T4 together, I'll order the TSH and then say, if TSH are normal, these are.
They won't do it. Will not do it.
So they will if you order a TSH and put hypothyroidism.
Oh, you can do that.
Yeah, and then you've got TSH, hypothyroidism, T4, then they'll order it still. But if you use the Life Labs standardized form, which they've tried to design to make it, TSH says TSH plus or minus T4, but if you write TSH, T3, T4, hypothyroidism, they'll still have it. And become aware of your practice profile. So this is I don't know if you all read your practice profiles, but the BCMA every year sends us for the residents. The BCMA every year sends us a collation of all the different things we're doing and comparisons to our provider group, similar provider group. So all the family physicians in BC will have an average of how many consultations we receive, how many gonorrheas, and how many alkaline phosphatases up, for example. So you can see on here, I'll read them out to you. This is a standard line for all of the physicians in BC, and you can see I was in my first year when I arrived, way over to the right on ordering of all of my liver function tests, and that was because I was ordering a set on my ENR, and I didn't think about the fact that they probably only needed one of the 5 liver tests, and everybody else was just ordering one of them, ALT, and I was ordering a whole bunch with bilirubin as well. And so then I realized, maybe I should be changing my practice a bit, because everybody else is doing something a bit different. And so I made a change in my practice. I changed the way I ordered things after that. But you can see the blue one is the primary base fee, which is how many lab tests I'm ordering. So I'm ordering on average less lab tests than other people, but I'm somehow ordering a whole bunch of more liver tests than everybody else. And these flags on this made me quite anxious. These little flags on these things here, there's like 2 flags, 3 flags. So compared to other people, I was quite a long way out of the range. And then this is me 3 years later. So the same comparison group. And you can see the primary base fee, I'm still ordering less tests than everybody else, by just a little bit. But on average, my liver tests are all about the same. And then I also use this to try and become familiar with what my colleagues are doing around the products. So these are the 3 that are much lower than everybody else. That's how many cholesterols I'm doing compared to my colleagues. So I'm ordering a lot less cholesterols than most of the physicians can see. So I need to make sure that when I have a chat with my patient about whether or not they need a cholesterol, we discuss it and they're comfortable knowing that we're not doing the cholesterol not because we're not interested, but it's because it's not going to change our cholesterol. And I was going to try and show you, unfortunately we can't, I was going to try and show you some example sites of these. So Dynamed is probably my first go-to because it shows the level of evidence for interventions. And then Medimask, I highly recommend if you haven't used Medimask before. It was designed by a physician in Victoria. And I go to it probably a couple of times a day. It has in it all the recent, most up-to-date guidelines for obesity, but also it has a list of drug costs for obesity. And if you search on, there's a list, if you search for the generic name of the drug, it will tell you the name of the drug, whether or not, what types of pharmacare coverage, and then TRIP database I use quite a bit for...
What is the website?
TRIPdatabase.com. Yeah. So, and actually all of the websites are in I think we're going to try and circulate it electronically.
They're on
The flash drives?
Yeah, so on the flash drives. We tried to circulate it by paper, but also by a flash drive. If you open that Word document when you go on your computer,
And that's fine.
all of the web links are active in that Word document. You just click on that Word document and it takes you to it. Same as my practice website. And again, it's a real shame I can't show you this cardiovascular risk disease calculator, but James McCormack designed one, and it's a kind of combination of the modified chromium and all of the most recent evidence around the therapeutic benefits of different prescriptions. So I can bring up, there's 100 green faces, and as I bring up, you can put the male 55-year-old non-smoker who's not diabetic, who has a cholesterol ratio of this, and HDL of this, and a family history of this, and then it'll tell you how many red faces there are as to people that are going to have an event regardless of what we do, how many pink people there are as to people that are going to have an event, and we can maybe do something about that, and then the green people are how many people are not having an event. And the event could be, you can screen for either cardiac death, any cerebrovascular cardiac event, and just MIs. And then you've got a bunch of buttons on it. If you go to the website, you've got a bunch of buttons for metformin and statin and exercise and Mediterranean diet and those things, which when you click on it, it tells you how many of the pink people you've now saved. So from having that event. Usually the lifestyle modifications are much better than the statins for almost everybody. But I use that not just because I want to explain, it's actually better for you to go out and get walking and use a Mediterranean diet than it is to take a cholesterol pill, but also because when I give them a cholesterol pill, it's not that you can stop having a Mediterranean diet and start walking. You still need to do all of those things to get the added benefit of all of them. So what are the next steps for you? I think the most important thing, and hopefully this is enthusing people to start wanting to learn more, and those resources I've given you are going to help to try and work things in a little bit. There's a long list of videos and resources that I don't want you to go through now. In fact, I'd encourage you to let it percolate for a bit, and then look at it again in the next couple of weeks over, once a month, maybe look at the resources in the web links and try and seek out new sources. And the most important thing is it's not finding the only up-to-date resource, it's using all the background knowledge you have in the previous guidelines along with any new evidence that's being brought to light. And it took me about 10 years to get to where I am now. I still think I'm in the process of improving how I practice evidence-based medicine. But it's taken a long time for me to get around to it. I still go to my evidence-based medicine retreats for part of UBC, and I hear about how my colleagues are doing way more than me and learning way more about different guidelines than I do, and I feel uncomfortable, and then I realize, well, they've just had a patient with that, or they've just had a session of education on that. So it's not that anybody knows more than me or more than us, it's just that we all need to keep learning, but learning from each other and learning the quickest way to get to the answers that we need. And then, look at the resources. Hopefully you can get it in an electronic copy, so you having to type in the website address, you can just click on the links. And if you want to, go to my website, it's there too. Does anybody have any questions?
Is Dynamed through the CME?
Yes.
And is that
Yes.
what you
In
link
fact,
to?
now that I've finished the presentation, perhaps I can do it. Yeah. Oh, okay. Yeah, it's pretty small. Let's see if I can. So the Dynamed, if you don't have a login for CMA, well, I think everybody has a login for CMA if you're an member. But if you click on
Is that Ed's asking if there's any passwords or anything that are needed for those sites that people see?
for everyone but the Dynamed site,
Is free.
yeah.
Yeah.
The Dynamed doing that you need a password for. Up to date is only free, I think, if you're part of a clinic that has access to that DPA, the DC Provincial Network. Otherwise, you need to have a login, and it's free in all of the female computers up to date. Otherwise, you have to have subscriptions.
You just have to log into College of Family Practice, and then you get it's okay for 3 months or something.
Exactly right. Yeah. So the College of Family Practice and the divisions also can access up to date without accessing the without being part of the or being a